Dr. Choll Kim here from San Diego. I have Dr. Larry Lo from New York, and I want to just say one word to you: sciatica.
That's right.
So that's probably the most well-recognized term, at least in my practice, from my patient's perspective. So you could have sciatica is really injury to the sciatic nerve, which goes down your leg, but everyone uses it for radiculopathy, which is a pinched nerve. You could have that both in your neck and your back.
Right.
What are the common features of cervical and lumbar radiculopathy? Because obviously they're two totally different areas of the body.
Right. I would say that, as you mentioned, like sciatica is probably our most common complaint in terms of patients coming to clinic. In terms of lumbar radiculopathy, or pinched nerve in the lower back, it classically presents as pain in the lower back that radiates down the buttock into the leg. I would say a lot of patients have that complaint. And the cervical or the neck version of that is very similar, where patients have some neck pain that radiates to the shoulder, into the arm, into their hands. So they're both actually fairly similar in terms of how they present, just different parts of the body.
And from a patient's perspective, what should I be concerned about? When should I be rushing off to see a spine surgeon?
I would say that if your pain is so bad that you're really having a hard time walking or even getting around, you can't drive, you can't even get up and out of bed. Another reason to go see a surgeon is probably if you have weakness.
Yep.
So let's just say that your pain is so bad in your neck that you're having a hard time lifting your arm up, or your sciatica, the lumbar radiculopathy, is so bad that you haven't noticed that you're having a hard time moving your feet. These are probably symptoms that would prompt a more urgent evaluation.
So things like, besides pain, because pain is probably the most common symptom that our patients suffer from.
Right.
And a lot of patients have a lot of pain for a lot of different reasons. But once you start having radiating pain down your arm or down your leg, down to your ankle, your foot, with some numbness and weird tingling symptoms, that's probably sciatica or radiculopathy. And then if you're weak, that's kind of an emergency, or that's an urgent problem that has a little bit of a ticking clock. Whereas pain, you can kind of, as long as you can live with it, you're okay. But when you have motor weakness, there's an issue with waiting too long. Is that right?
Absolutely. I think that oftentimes, even though the patient is coming in with weakness, if you really do a good exam, you'll notice that they don't have any sort of muscle loss, their reflexes are still good, their strength is actually quite good, and their weakness is actually more from the guarding from the pain.
That's a good point.
I do think that if the patient has true weakness, where let's just say that their triceps muscles are weak, they're having a hard time pushing against you, or they have a partial foot drop where there's a hard time lifting the feet up, walking on your heels or whatnot, then I would say that ups the urgency. We're probably a little bit more likely to recommend something surgical rather than trying non-operative management.
By the way, this word foot drop, that's another well-recognized term. But some people don't even notice that they have a mild weakness that we call foot drop until we examine them. And then a lot of my patients will say, oh, and by the way, I catch my toe and trip a lot when I walk. But I don't feel weak. Do you notice that too?
Absolutely. Because the pain is so severe, I think that tends to be the predominant complaint on the patient side. So they're oftentimes not noticing that, oh, when you're going upstairs, I noticed that like my shoes are getting sort of scuffed up because it's catching on my toes. So those are the types of questions that we ask patients. But because the pain is so bad, when patients come in, invariably, they tend to complain about the pain more than the weakness.
A lot of people come in with just the MRI. Because the MRI is the workhorse of spine diagnosis. We have to have an MRI pretty much on everything. What about x-rays? How important are neck x-rays and lumbar spine x-rays in addition to the MRI when you're trying to evaluate somebody with cervical or lumbar radiculopathy?
I think it might be old-fashioned, but I feel like there's a lot of information to be gleaned from the x-rays. Oftentimes you can actually see the hole where the nerve is coming out of very clearly on an x-ray. And I would say if there's bony compression of the nerve rather than soft compression from a disc, it might be a little bit less likely to respond to non-operative management. I think X-rays are one of the few tests that we do standing.
Yeah.
And so we get a lot of information about, oh, when you stand, how do things look? Because most MRIs, there are open MRIs where you do it standing, but most MRIs are still done lying down. And we get a lot of information by comparing the difference in how the spine looks when you're lying down versus standing. And oftentimes with X-rays, we'll actually even have patients bend back and forth and get different views. And I think there's a lot of information that helps us sort of determine the outlook of the patient's radiculopathy as well as what approach we might take from the X-rays.
All right. Correct me if I'm wrong, but eventually we will just rely on upright MRIs with flexion extension views and avoid having to get X-rays at some point. But what I noticed, at least where I practice, a lying down MRI, you can get like a 3 Tesla magnet.
Right.
And get really close to the body, and you get really high resolution images.
Right.
All the MRIs that I see standing up,
right.
they're further away, the magnet's weaker, and it's much grainier.
Right.
So, in my mind, I don't think the upright MRIs are going to be good for everything until it gets more higher resolution. Would you agree with that? Or?
Absolutely. I think that the field strength is so low on an upright MRI that in terms of the fine details, let's just say that we're looking for sort of a unique type of disc herniation, like a far lateral disc herniation where it's not in the spinal canal but off to the side. I feel like on an open MRI, it's very hard to pick up those fine details about, oh, is there a layer of fat between the disc versus the nerve or whatnot. So I do think that as of right now, there's still a substantial role of getting a traditional MRI. Oftentimes, if the patient comes in with an upright MRI, I'll tell patients that I can't do surgical planning based off of that, so we need to repeat them. Because oftentimes they're getting the upright MRI because they're claustrophobic.
Right.
So they're coming in with that, and we look at the scans and we're like, no, we don't see enough to determine exactly what your pain generator is. So then we sort of repeat, unfortunately, the traditional closed MRI.
I feel so much better about myself. I've had the same experience.
Yeah.
All right, let's talk about treatment.
Yes.
Because it turns out the treatment kind of strategy for cervical radiculopathy and lumbar radiculopathy can be quite different. So let's just start with the neck. Let's say me, 59, spine surgeon. I have neck pain going down my right arm with some weakness with grip. And I can just do my daily things, but during surgery, I'm starting to struggle, especially with long surgeries. And I've already tried physical therapy and things like that. What would my treatment look like? I have a 2-level problem.
I would say that almost certainly the best option is just a foraminotomy in terms of taking the pressure off the nerve without performing any type of fusion.
From the back?
From the back. There are surgical approaches, which obviously you're very familiar with, coming from the front, doing an anterior foraminotomy as well, but in my practice, I tend to do a posterior foraminotomy.
I wonder if you're somewhat unique. Is that what most of your colleagues in your area do? Because in San Diego, we go from the front way more often than going from the back.
I would say that in the New York area, oftentimes, that absolutely matches what you're saying, which is I would say they tend to come in from the front. And if in terms of a motion preserving strategy, probably do sort of a 2-level disc arthroplasty instead of a sort of a pure foraminotomy coming in from the front. I think there's pros and cons of each, of course, and a lot of it depends on sort of what your alignment is like and whatnot. But I would say that both are good options in terms of ultimately the goal of the surgery is to take the pressure off the nerve and address the radiculopathy and the weakness you're having in your arm. And the question is sort of what is the least morbid way of achieving that? I think that if the disc is far out to the side, I think coming in from the back is perfect because we have a great access to it. On the other hand, if the disc is more in the spinal canal, more often the center, we have a hard time getting to the area coming from the front and coming from the back, and coming in from the front is the better approach.
That makes sense. Again, luckily we have lots of different approach options so that we can, customize our treatment to the individual patient and look at every single detail. It would be like building a Rolls Royce by hand. Now, one thing about cervical radiculopathy and its treatment compared to cervical myelopathy, so some patients have just the pinched nerve going down one side.
Right.
Other patients have compression of the spinal cord.
Right.
They're kind of two different problems that kind of you look at differently, right?
Right.
Tell me more about that.
Yeah, so basically although it sounds the same, a pinched spinal cord versus a pinched nerve, from a clinical perspective, the urgency is completely different. So let's just say you have a pinched nerve and it went untreated for reasons that are unclear, you just left it alone. The worst thing that would happen is that you might have some permanent weakness in the muscle groups that one nerve innervates. So if you have a C6 nerve problem, radiculopathy, you might have some weakness of your biceps.
Right.
On the other hand, if you leave a pinched spinal cord untreated, the ramifications are catastrophic. You might actually lose function of both of your hands. You might actually lose the muscles in your hands. You might actually lose your ability to even walk. You might even be in a wheelchair if it went untreated. So it's very, very different. I would say for the patients with a pinched spinal cord or cervical myelopathy, we tend to offer surgical decompression much sooner rather than somebody that has a pinched nerve or radiculopathy.
Now let's talk about the lumbar spine, because the spinal cord ends at around L1.
Right.
So below L1, so where most of the problems are like at L4-5 and L5-S1, the spinal cord ends and it's just what we call the cauda equina, the nerve roots just hanging down like a horse's tail.
Right.
So when you have stenosis versus radiculopathy in the lumbar spine,
Right.
it's not that big of a deal in terms of a surgical emergency. Would that be fair to say?
I think that's a fair statement.
So let's imagine me as a patient with a 4-5 disc herniation.
Okay.
I have dorsiflexion weakness, and I have the sitting on one butt cheek sign. I can only sit on the butt cheek opposite my leg. And when you walk in, I'm like this, and I'm like, hello, Dr. Lo.
Right.
I've already tried PT and acupuncture and chiropractic care. It's been 6 months.
Right.
Now what?
I think this is where in the lumbar spine we have a lot of exciting approaches. And I think that ultimately, I think the procedure to do would be to address the radiculopathy and take the pressure off the nerve. But there's many, many different ways that we can approach that. We can approach that with a traditional microdiscectomy that involves basically removing a little bit of bone with a posterior incision coming in from the back. We remove the disc fragment that's pinching on the nerve. There's also minimally invasive options where we do that same procedure, but through a tiny tube rather than making a big old incision. Then there's even endoscopic options where it's actually even just a puncture. It's a stab incision off to the side where we actually work through endoscopes to remove that disc fragment.
My favorite.
Right? And there's even awake options of that, which I think is the most exciting, where the patients are actually not undergoing general anesthesia and we're able to remove the disc fragment with them. They go home the same day, they do beautifully. So I think we have a lot of great options in that scenario.
You know, a patient with a lumbar radiculopathy due to a herniated disc that I have to do surgery on, that's my favorite patient.
Right.
Same for you?
Absolutely. Their pain relief is instantaneous. They walk out of the hospital very happy. I do think that it's a very satisfying patient population to treat.
Yep. If you're going to have a spine problem that needs an operation, that's the one to have because the results are really outstanding.
Absolutely.
I agree with that. I know it's a big topic because we talked both about the neck and the back, cervical and lumbar radiculopathy. For our patients, how would you kind of summarize the things that are the most important for you?
I would say that because it's so common, don't freak out. It's definitely a treatable problem. I think the key in terms of potentially seeing a spine surgeon sooner is if you feel like you have weakness. I would say that that's sort of the tiebreaker. I would say 9 times out of 10, we see a patient with radiculopathy, their strength is good, and we try non-operative management and it works well, right? We lean over that, but oftentimes you can, just because you're seeing a spine surgeon doesn't mean you're getting an operation. But then if you are noticing that, oh wow, like my biceps are really weak, or the dorsiflexion, the foot drop, you're having a hard time moving your feet, that's probably when you should see a spine surgeon on the sooner side rather than trying non-operative management first.
So pain and maybe numbness can go on for a long time without worrying too much.
Right.
When you have motor weakness, there's a little bit of more urgency.
Correct, because what we're trying to do is to avoid that motor weakness to be so persistent such that we started losing muscle mass. Once we start losing muscle mass, it's very difficult to recover that. So I would say that that's when we start really thinking about, oh wow, you have profound weakness that's not really responding to non-operative management. That's the patient population that we're offering surgery for.
Makes sense. Thank you very much, Dr.
Thank you very
Lo.
much.